Welcome everyone, I'm Steve Walker and I'll be moderating today's educational webinar about the role of procalcitonin in the diagnosis and management of sepsis. On behalf of bioMérieux, I'd like to thank all of you for joining us today to explore this topic as it pertains to the clinical laboratory. It's my pleasure to introduce Dr. James Fay from Stanford University School of Medicine, who will be presenting Controversies in the Use of PCT to Diagnose Sepsis. Dr. Fay is Director of the Clinical Chemistry and Immunology and Associate Professor of Pathology at Stanford. His research interests include markers of sepsis, myeloma, autoimmune disease, and allergy. He's active in the American Association for Clinical Chemistry as well as the College of American Pathologists. So for the next 30 minutes or so, Dr. Fay will be exploring the increased incidence of sepsis and how the use of PCT can be used as a diagnostic test in this setting. He'll address limitations of PCT testing and frame questions that need to be answered for PCT rapid assays as they become more routinely adopted by clinical laboratories. Then following Dr. Fay's presentation, we have allowed time for questions and discussion. So with that, Dr. Fay, I'll now turn it over to you.
Okay, thanks very much, Steve. I'm happy to host this webinar. It's actually an exercise that I conducted myself after hearing a lot of people being interested in procalcitonin but wondering whether it was ready for prime time. We recently implemented it here at Stanford, and there are a lot of questions about it, and I thought it would be useful to try to address those questions primarily by going through the literature that's been published on procalcitonin and trying to tease out of the literature answers to some of the common questions about its use in the routine clinical laboratory. I just want to start by reminding everybody why sepsis is so important and why markers help us identify people at risk of developing sepsis, especially severe sepsis, are something that we should continue to be working on. Sepsis is the presence of an immune response to infection that's characterized by an acronym called SIRS, Systemic Immune Response Syndrome. It's defined pretty well, but it's not that extreme, really. It's defined as just fever, an elevated white cell count, and an elevated heart rate or respiratory rate. And the presence of this immune response with an infection is called sepsis, and it has a relatively high mortality. It probably is primarily in patients who have very severe infection or very severe SIRS. And then, in fact, there's a definition of severe sepsis, which includes organ dysfunction of any type. And as you can see, this has a very high mortality of 50%. So trying to identify people who are at risk of developing sepsis, and especially severe sepsis, is a worthwhile goal. What the SIRS is, what the systemic immune response is shown in this slide. The bottom part of this slide is classic immunology. It shows that the macrophage, the antigen-presenting cell here, identifies bacteria in the tissue using a toll-like receptor, phagocytizes the bacteria, and then induces local inflammation by producing cytokines, inflammatory cytokines. And these inflammatory cytokines get out into the blood and they initiate a systemic immune response. If the macrophage is having trouble with the bacteria, or if the bacteria is especially dangerous based on the toll-like receptor motif, then it also calls in T cells to help it. The T cell recognizes the antigen expressed on the surface of the macrophage, and then that stimulates the macrophage to become more active. It also causes the T cell to make inflammatory cytokines, and so the systemic immune response is ramped up. A immediate target of this is probably the poly here that's circulating in the capillary blood. It's activated by these cytokines, but other targets include the bone marrow, where the poly comes from, obviously, and there's an increase in production of polys, and the liver, which is induced by these cytokines to make the acute phase reactants that we know are concomitants of inflammation. The story with procalcitonin is up here on the upper part of the slide, and it's not as clear, not as classic, obviously. It seems that this molecule, procalcitonin, is made by tissues in the presence of bacterial infection and also in the presence of other insults, as we'll talk about. The laboratory testing for this systemic immune response that we're going to focus on is primarily testing for the cytokines or procalcitonin or C-reactive protein, which is one of the acute phase reactants that the liver makes in response to the cytokine production. And this slide shows the sort of classic cascade of cytokines that are present whenever you have any kind of inflammation. Actually, it says here local infection, but it could also be any kind of local inflammation. These inflammatory cytokines produced by the macrophage and by the T cell are elevated first, and then the tissue procalcitonin rises, and then the CRP rises as well. IL-6 is a well-accepted marker of inflammation. CRP is certainly a well-accepted marker of inflammation and much more widely used than IL-6. PCT is the new kid on the block, although he's pretty old by now because he's been around for a long time. But there's still a lot of concerns actually about the use of any of these markers really for the diagnosis of sepsis or risk of sepsis, but there's especially a lot about procalcitonin, the new kid on the block. I just want to review briefly the early history of procalcitonin. As far as I can tell, it was first described in 1983. As most major discoveries in science and medicine, two different people discovered it the same year. That seems to always happen. And I think that both of these individuals were looking at the fact that patients who had septic shock, in one case meningococcemia and the other toxic shock syndrome with staph causing a sort of cytokine cascade due to it being a superantigen, I think that they recognized that some of these patients were hypocalcemic. It probably was the case that they were hypocalcemic because they had low albumin because of the increased vascular permeability that was present in the shock situations. But they were investigating whether calcitonin, a hormone that's known to lower calcium levels, was possibly involved. And oddly enough, they found that calcitonin was elevated in these situations. And then during the 1980s, it turned out that it really wasn't calcitonin, which in humans is really not probably physiologically related to any calcium homeostasis, but a calcitonin-related peptide, which turned out to be procalcitonin. And then I think a key study was published in 1993, where they looked at procalcitonin in patients with sepsis, as well as some other situations. And this report kind of characterized some of the key features of the procalcitonin response. There's a continuum of the PCT level, from no infection to local infection to systemic infection causing very high levels. It is true that it's not a specific marker of infection, and you can actually see elevated procalcitonin levels in non-infectious stimuli. In this particular study in 1993, they looked at burn patients. We'll talk about this in a little bit. And then they established that it was being produced not in the thyroid, where the parafollicular cells produce calcitonin, but actually all over the body in a number of different tissues. And then I just put this 1997 reference there because this was when I personally became interested in procalcitonin. It was in 1997 when there was an article in Arthritis and Rheumatism about how procalcitonin could help differentiate infection from the inflammation that's always present in patients with autoimmune disorders. That was and is my primary interest, autoimmune disorders. And I began to think of procalcitonin as a kind of cool infection-specific CRP. It's not that exactly, but this sort of set the stage for the next decade. A lot of papers were published comparing procalcitonin with CRP for the diagnosis of either infection or sepsis. And what I'd like to do is not take you through every single reference that I was able to find, because there's hundreds, but just show you the results of 4 major meta-analyses that were published during the last decade. But before I do that, I just want to set the stage by showing what I often cite as the key initial reference that compared procalcitonin and CRP for the diagnosis of sepsis. They also looked at IL-6 and lactate, I believe. This was a prospective study in ICU patients. They had about 100 patients in the study, and they measured these markers on day 1, 2, and at discharge. And you can see that about half of them either had sepsis or developed sepsis during their ICU stay. And you can see that the procalcitonin, like the IL-6, is not that elevated in the absence of SIRS or infection, but goes up once sepsis develops, and is very high in the presence of severe sepsis. And the most severe of severe sepsis is septic shock. And then using a receiver-operator characteristic curve, which is what we'll be showing for the 4 meta-analyses I'm about to show, this study demonstrated that procalcitonin had a much better performance for the diagnosis of sepsis, with both a higher negative predictive value and positive predictive value over the other markers that were used, including lactate, which is a commonly used marker in intensive care units to try to estimate the risk of sepsis development. I'm about to show these 4 meta-analyses. Most of these meta-analyses have taken hundreds of articles and winnowed them down to about a dozen, and there's a lot of questions and concerns about how articles are chosen and how they're eliminated. I often say that we need a meta-analysis of meta-analyses just to kind of determine the state of the art. But I think it's very important as we set the stage and we look at receiver-operator characteristic curves of the meta-analyses, which group numbers of studies together, is what exactly what are we trying to diagnose? In other words, are we trying to diagnose sepsis or severe sepsis or just bacterial infection? That's an important consideration. And then what is the population that we're looking at? And the reason why these two questions are so important when you look at any of these studies is because obviously what you're trying to define is important, and secondly, the population is very important because the pretest probability will have a major impact on the usefulness of a marker. And the reason why it's so important to define what you're actually looking for is because you need to also consider what the prevalence of the thing is. For instance, in this study, we know that the prevalence of sepsis, because half the patients develop sepsis, the prevalence is 50%. And we know that the performance of a test, even with the exact same sensitivity and specificity, will deteriorate markedly when the prevalence falls, because this is especially true of the positive predictive rate, because with a very low prevalence, it's more likely that a positive result will be a false positive. So we really need to consider all of these factors as we look at the way that procalcitonin is used. So let's just march quickly through these four meta-analyses. The next slide shows the first one. It was published in 2004, and it included 12 studies, and this was in hospitalized patients, so patients on the floor, not in the intensive care unit, and was looking at PCT versus CRP for the diagnosis of bacterial infection. And it showed that PCT performed better. Tests that perform well are up in the upper left-hand corner. They have very high sensitivity. They pick up everybody who has the disease, and they don't call anyone who doesn't have the disease positive. I'm kind of surprised that PCT didn't do better than CRP, but obviously there were some studies that showed probably CRP doing better than PCT. The next one is from 2006, 2 years later, and this one was in ICU patients. This, I think, is what we should be looking for. We should be looking for the marker to define someone who has sepsis or has severe sepsis or is at risk of developing severe sepsis. I'm going to sort of say that several times because I really think it's important. This meta-analysis had 25 studies, and it was in ICU patients. And I would say that this shows that both markers are pretty similar. There's actually receiver-operator curve characteristic areas under the curve. This is actually a pretty significant difference between the two, but there's not a marked difference between PCT and CRP in ICU patients. The third one is not that helpful. This was a study in the emergency department, so again, the prevalence of sepsis is probably relatively low compared with an intensive care unit. And they were looking only at PCT's ability to predict whether or not the blood culture would be positive enough. There are a number of papers that have looked at this that actually does predict whether the blood culture is positive or not, and that may be a helpful use, but it's not the one that we're really focused on today.